I'll be presenting our paper on the use of wire-guided localization and radio-guided occult lesion localization for non-palpable breast lesions. This is a systematic literature review and meta-analysis of current evidence. So a little bit of background. Around the world, breast cancer continues to be the most common malignancy diagnosed in women and is still the leading cause of cancer-related death in women. Breast cancer screening aims to reduce the mortality from breast cancer, as well as the morbidity associated with advanced stages of the disease by early detection in asymptomatic women. The National Health Service breast screening programme was first introduced in the UK in 1988. And it sees over 2 million women who are invited for breast cancer screening annually. The National Health Service breast screening program invites all women aged between 50 and 70 years for screening every 3 years, provided that they are registered with a general practitioner. Since the introduction of the breast cancer screening program, there's been an increase in the diagnosis of non-palpable breast cancers. Breast-conserving surgery with adequate tumor resection margins is considered to be the gold standard treatment for early non-palpable breast cancer. This is because breast-conserving surgery is comparable to treatment by mastectomy when measured in terms of disease-free and overall survival rates. The aim of breast-conserving surgery is to achieve good cosmesis through minimizing the volume of resection of healthy breast tissue and also reduce morbidity. The ideal localization technique should be able to localize the lesion precisely. It should not be painful. It should reduce the time needed to localize the lesion and reduce operative time whilst maintaining ease of localization. Around 1/4 of breast lesions which are suspicious radiologically are non-palpable. Currently, wire-guided localization is the localization method of choice for many centers around the globe and is currently the most commonly used technique for non-palpable breast cancers. In the UK, these wires are usually inserted by breast radiology teams on the day of operation using either stereotactic or ultrasonographic guidance. This is then checked by a monogram to ensure the correct positioning of the wire, which in turn allows the surgical team to use the wire to guide them in successful excision of the lesion. Wire-guided localization is not without its own challenges. The biggest concern for patients and clinicians alike will be that in some literature, compromised resection margins have been reported in the range of 12 to 60%. This invariably mandates the need for a second general anesthetic and reoperation. On top of this, wire-guided localization can be challenging to place, especially in young, dense breast tissue. And often, the ideal site of entry for the wire is distant from the ideal cosmetic incision the surgeon is likely to make, which may result in extensive tissue dissection. Other complications are that the wire may dislodge or be transected during transfer of the patient, which means that precise localization of the cancer is not possible. Radio-guided occult lesion localization is a more recent technique for localization. A radiotracer solution is injected adjacent to the lesion under radiological guidance. Just prior to surgery, a small dose of nanocolloid labeled with radioactive technetium is injected into the tumor site. Surgical excision is then performed using a handheld Geiger counter. The handheld counter is used to measure radioactivity with maximum radioactivity corresponding to the center of the lesion. This aids to guide the skin incision and can be used to confirm excision by checking operation sites for residual radioactivity. Roll has been shown to be preferred by surgeons as well as reducing operative time. Our primary aim for this systematic review of meta-analysis was to compare re-resection rates between wire-guided localization and roll. Our secondary aim was to assess and compare margin involvement, accurate localization, volume of specimen, weight of specimen, localization time, and operative times between wire-guided localization and roll. A systematic review was performed according to PRISMA guidelines. A comprehensive literature search using free text terms was undertaken using both Central, Lilacs, Medline, and M-based databases. Following a comprehensive search, 2 reviewers assessed titles and abstracts and excluded articles that did not meet the inclusion criteria. Both the reviewers screened the remaining studies for detailed evaluation for eligibility. Any disagreements were resolved by consensus-based discussion, along with the involvement of a third author. Our inclusion and exclusion criteria are outlined in this table. Inclusion criteria included randomized controlled trials, publications in English, comparing wire-guided localization and radio-guided occult lesion localization, objective evaluation of at least one intraoperative outcome, which included re-resection rates, involved surgical margins, excised specimen weights, excised specimen volumes, surgical operative time, localization time, and successful localization. Our exclusion criteria included studies published in languages other than English, non-randomized controlled trials, retrospective analysis, cohort studies, case reports, review articles, commentaries, letters, and editorials. Other localization methods such as radioactive seed localization and mag seed localization were also excluded. Studies where outcomes of interest were not clearly reported or easily accessible were excluded, as were animal studies and duplicate studies. This slide just shows the PRISMA flow diagram of the included studies. A total of 120 potential studies were identified by this search strategy, of which 105 were excluded on the basis of title or abstract. For the remaining 15 articles, the full texts were obtained and reviewed. 9 randomized controlled trials were identified to have met the inclusion criteria. The 9 randomized controlled trials included a total of 1,096 participants, all with non-palpable breast lesions. The trials varied in their inclusion criteria and included both non-palpable benign and malignant lesions. There was variability in the case definition of clear resection margin. No statistical difference was reported in any of the studies regarding the patient's age. Meta-analysis of 7 randomized controlled trials demonstrated no difference in re-excision rates between wire-guided localization and roll. Regarding non-involvement of margins, 7 RCTs were included in this, which demonstrated statistically fewer margins were involved of the resected specimen in the roll group compared to the wire-guided localization. 5 randomized controlled trials contributed to the meta-analysis of the localization time, which demonstrated a significantly shorter localization time in favor of roll. All 9 randomized controlled trials provided data on length of operation, which demonstrated significantly shorter operating times in favor of roll. The results from 6 trials regarding weight of specimen did not demonstrate any difference in specimen weight between the 2 arms, that is roll and wire-guided localization. Similarly, for volume of specimen, there was no difference in the specimen volume between the two arms. Meta-analysis of 8 trials did not demonstrate any difference in success of localization between the two procedures. Regarding proportion of cancer diagnoses in these trials, only one study excluded any biopsy-proven malignancy. The remaining 8 studies had various proportions of cancer patients contributing to their results. There was no statistical difference in the number of cancers in each arm of the study. We could not perform a meta-analysis on the ease of use of role and wire-guided localization. However, the studies reported a subjective ease of use of role over wire-guided localization. These next 2 slides shows the forest plots for each outcome. Our study compares 2 commonly used localization techniques for non-palpable breast lesions by analyzing 9 randomized control trials involving 1,096 patients. 2 previous systematic reviews and a Cochrane review have previously compared these 2 techniques. However, there have been 3 further randomized control trials researching the 2 localization techniques of interest since. The pooled results show that the use of roll significantly shortens the time of image-guided preoperative localization of non-palpable breast lesions under the guidance of either stereotactic methods or with the use of ultrasound. Surgical operative time was also found to be significantly shorter in the roll group. This has also previously been shown in the systematic review conducted by Ahmed et al. And Sajid et al. Perhaps this is because of the placement of the needle wire is more complex than roll, and the gamma probe used in the roll directs the incision, and has the capability of checking the lesion position as often as needed during the surgical procedure. One other potential reason for decreased localization time and operative time may be explained by the subjective ease reported by radiologists and surgeons alike when using roll compared to wire-guided localization. The most important surgery-related factor for local recurrence is completeness of excision of breast cancer. The current practice varies in respect to what is clear margin and is dependent on country. Recent consensus based on 2 meta-analyses and the views of an expert panel suggests that the positive margin is defined as the presence of invasive or in situ cancer at the resection or inked margin. The meta-analysis found that tumor at the inked margin was adequate, and in fact additional margin distance did not significantly improve tumor recurrence or survival. The majority of units in the UK accept that a 1 mm margin is sufficient based on the findings of these 2 meta-analyses. Analyzing all results from the included randomized control trials, our results suggest that the use of roll significantly reduces the likelihood of involved resection margins when viewed compared with wire-guided localization. One explanation for this could be due to the better lesion centricity in the roll arm, thereby allowing the surgeons to use the gamma probe more confidently excise the tissue of interest. The surgeon would be guided by the frequency and intensity of the radioactivity. Therefore, as it diminishes, they will know that they are far from the center of the lesion. It also provides a three-dimensional pseudo-image with a gamma probe. In wire-guided localization, there is no immediate feedback, as it is more based on surgeon experience and judgment. Our findings of the pooled outcomes from the 2 large randomized control trials, coupled with the 5 other randomized control trials, suggests that although the risk of resection is lower in the roll group compared to the wire-guided group, this does not reach statistical significance. There was moderate heterogeneity observed between the 7 studies. This is in part reflected by each study having a different inclusion criteria. This does, however, provide a more global idea of what could be expected if roll is more widely and routinely used. However, newer guidance is suggesting a move away from diagnostic biopsy. This is, however, not a drawback of the randomized control trials, as some were published prior to the new guidance. Limitations and future work. As evidenced from this meta-analysis, it is clear to see that the inclusion criteria for each of the studies is quite heterogeneous. Some studies have included diagnostic excisions, whereas others only proven breast cancers on biopsy. It is important to note that since the publication of some of these articles, there has been a move away from surgical excision biopsy to more percutaneous biopsies, and therefore the results reported may not be necessarily applicable in today's management. The consequence of these diagnostic excision biopsies is that studies had high proportions of benign lesions. The resultant outcome is that there may have been potential bias when analysing the outcomes of malignant disease in terms of margin status, reoperation rates, and volume of specimen. Unfortunately, due to the current limited evidence base, we were not able to only include biopsy-proven malignant cases. Our recommendations based on the analysis is that any future randomized control trial should be adequately powered, multi-centered, and investigate biopsy-proven cancer lesions or B3 lesions, which cannot be excised using vacuum-assisted technology. Thank you for listening. Do you have any questions?